Dr. Kuo is going to be able to share with you, the clinical side of why what happened to me and all the different scenarios of, what we experience on this journey to parenthood. And last week we had the pleasure of co-presenting a continuing medical education course for social workers at UCLA that went over really great. So I'm very excited and honored to share the stage with him this evening. So thank you so much for being here and for giving me a chance to share my story.
So I'm John Kuo. I'm a reproductive endocrinologist, and I wanted to thank Dr. Casarelli and the Simsman UCLA Center for Integrative Oncology for the opportunity to present to you on parenthood after cancer diagnosis, fertility options from diagnosis to survivorship. So in 2013, the American Cancer Society estimates about 1.6 new cancer diagnoses. And of these, about 11% are reproductive age men and women. And in these women and men, a lot of these cancers, such as leukemia, lymphoma, breast cancer, cervical cancer, they're very treatable. So a lot of these men and women will survive and then want to have children in the future. So this is a very important talk, especially before the chemotherapy and the radiation starts, to know your options. So gonadotoxicity is what I'm talking about. The gonads are the testes and the ovaries. And this is where the sperm and the eggs are produced. And there can be damage from chemotherapy and radiation to these organs. The actual damage varies depending on the age when you receive the chemotherapy and radiation. It also depends on the gender. So in females, the prepubertal ovaries are less vulnerable to the radiation and chemotherapy. So the earlier you get the radiation and chemo, the more the chances that your ovaries and your eggs will survive or that you will still have periods afterwards. In males, it's just the opposite. So the earlier in the prepubertal testes, if you get chemotherapy or radiation, then there's more damage and the effects are more severe. So one of the reasons is in females, you're born with all your eggs. So we kind of see that the maximum number of eggs actually occur before you're born. At about 24 weeks of gestation, you have about 5 million eggs. By birth, it's down to 1 to 2 million. And then by puberty, it's to 300 to 500,000, and then in menopause is usually less than 1,000. So the earlier you receive the chemotherapy and the radiation, there are more eggs that are present, there are more eggs that will survive. So radiation, specifically in females, don't worry about the actual dosages. This is very technical, but the average median lethal dose for the eggs is 1.99 gray, and you can kind of see the numbers that as you get older, it takes less radiation to make someone sterile. This is whole body radiation numbers. The good thing about the uterus, where the pregnancy occurs, is that usually chemotherapy does not damage the uterus, but the radiation can. So if you get high dose radiation, especially early on, you can damage the uterus and the lining where the implantation would occur for pregnancy. So a prepubertal uterus is actually more vulnerable to the radiation, and sometimes you get a smaller uterus and you can have more pregnancy complications. In males, the quality of the sperm or the shape, the morphology can change even with a little bit of radiation at 0.1 gray. So the permanent azoospermia means basically that there's no sperm being produced when we do a semen analysis to look at the sperm. And that's about 1.4 gray. The Leydig cells are cells that produce the testosterone. And these cells are more hardy. They're able to survive the radiation better. So even if you're sterile, meaning that you don't produce sperm, you can still have testosterone production. So even though you have testosterone, the sperm may still be affected. Chemotherapy, they go into very different risk groups in terms of being gonadotoxic. I'm not going to go into the details, but the good thing is that it doesn't usually damage the uterus. So women, even if they're not able to have children from their own eggs, they're usually still able to carry a pregnancy. In females, the average age of menarche, which is the start of menstrual periods, is 12.54 years. And this is important because the treatment before menarche and after menarche are different. If there is uterine or endometrial damage, the option of pregnancy becomes basically the use of a gestational surrogate. So somebody else would have to carry the pregnancy if you cannot use that uterus to carry your pregnancy. So fertility preservation options, there's 2 slides. One is for the prepubertal women, and then there's the postpubertal women. So prepubertal includes ovarian shielding, so basically lead shielding over the ovary areas in the pelvis. There's ovarian transposition, which is a surgery. If you're going to have radiation to the pelvis, they can actually mobilize the ovary and move it out of the pelvis, out of the radiation field. There's still some scatter radiation, but it's less effect on the ovaries. There is some risk when you take the ovaries out of the pelvis, you're reducing some of the blood supply to the ovaries, and that can also damage the ovaries because of the lack of blood supply. Some of the newer experimental options are to cryopreserve or to freeze ovarian tissue so that you can transfer that back later in order to conceive. And then there's cryopreservation of in vitro maturation oocytes. What that means is that you either take the entire ovary, or you take pieces of the ovary, or you insert a needle and try to get small immature eggs and basically mature them in the lab. Postpubertal, those options are exactly the same. In addition, we have 2 more options that we can do. One is standard in vitro fertilization, where basically the female will take injections of hormones, stimulate lots of eggs to grow in the ovaries. We basically retrieve those eggs under anesthesia, and those eggs can be frozen or fertilized, and then the embryos can be frozen. So unfortunately, this takes a longer period of time because you have to stimulate the ovaries, and standard IVF protocols can be anywhere from 2 to 6 weeks in duration. And then the last thing is gonadotropin-releasing hormone, agonists and antagonists. This is just a medical term. Basically, these are medications that will put you into a medical menopause. So basically, it shuts down the ovaries, reduces the function. The thought is to try to rest the ovaries, make them metabolically inactive so they're less susceptible to the chemotherapy. So this is the picture of different shielding. The one on the left, it's for testicular, depending on the size that you want to shield. The one in the upper right is for ovarian shielding, and then you can use also a lead apron to protect the gonadal areas. This is ovarian transposition. So this is basically 4 pictures from a laparoscope, which is a camera surgery through the belly button, and we're looking into the pelvis. On the top left, the big red thing is the uterus. The whiter area where those instruments are is the ovary, and then there's a fallopian tube along the outer, upper, and right side. So what they do is they basically free up the ovary. They basically incise the incision basically from the uterus to the ovary, and then the tissue that connects the ovary to the fallopian tubes are dissected, and then the ovary is flipped up out of the pelvis, usually sutured in, and they usually put a clip there to kind of mark where the ovary is. So this is only for people who are going to get pelvic radiation. I'm going to talk a little about in vitro fertilization. So in vitro fertilization has been around since 1978, which is the first baby that was born. This is in the United Kingdom. This is Louise Brown. So standard IVF stimulation protocols is a little bit more technical. Upper left, the M is just the menstrual period. Typically what happens is that women will get their menstrual period, will be on a short course of birth control pills to downregulate their ovaries. We don't want any dominant follicles. We want everything to be small so they all grow together so we can get the maximum amount of mature eggs. Then they will take gonadotropin, which are basically medicines, they're LH, FSH, medicines that stimulate the ovaries to mature eggs. And typically the shots will take about 7 to 10 days to mature your egg. During this time, we will either give you a GnRH agonist, usually before the stimulation, or GnRH antagonist during the stimulation, and that's to prevent a premature ovulation. So what we don't want is you to basically have an LH surge, ovulate, lose those eggs. We want to keep them in. Then when we believe that the eggs are mature size based on ultrasound and blood work, we'll give you an HCG shot. The HCG shot mimics the body's LH surge, which triggers ovulation. Usually 36 to 48 hours later, the woman will ovulate. So at 35.5 hours, we retrieve the eggs. That's usually done under anesthesia. In this picture here, the eggs actually grow in what's called follicles. These are fluid-filled spaces. So on the upper right, on an ultrasound view, these are the dark circles that you see there. Each of those are a follicle. They contain 1 egg each. And under ultrasound guidance, usually transvaginal, a needle is inserted under ultrasound guidance into each of those follicles. The fluid and the eggs are aspirated. It's collected in the test tubes, and it's taken to the lab and basically separated. So in this view, the ovaries are quite small, but when the ovaries are stimulated, it's actually quite large, and it sits right behind the vaginal wall. So you can freeze embryos at different stages, typically day 2, day 3, or day 5. Technology has gotten better, the labs have gotten better, so we usually will go to day 5 now. So this is a picture of a day 5 embryo. It's called a blastocyst. There's about 70 to 100 cells. The left side at the 9 o'clock area is a inner cell mass. That's the actual embryo. There's a fluid-filled structure, which you can't really see on this one. So this is basically cut, but the other cells around the outside are basically forming the placenta when the baby implants. So at this stage, there's about 70 to 100 cells. It's much more advanced, and this is usually the stage that we freeze. So you can also freeze eggs and not fertilize into an embryo. And egg freezing or oocyte cryopreservation has been around since 1986, which is the first live birth from egg freezing. Since then, technology has slowly gotten better. It used to be a very slow freeze. Now we do a very fast freeze, and their survival rates are a little bit better. However, they're still fairly low. The live birth rate per egg retrieved is about 3 to 5%. So usually when we retrieve eggs, we want to retrieve a good number of eggs so that your chances will be higher. So I just had one of these cases this morning where someone who has basically lymphoma basically has recurrent, but she's basically freezing her eggs. So we got 47 eggs for her today. Yeah. So in 2009, they reviewed the egg freezing, and then they looked at the births and see if there's any birth defects. There was no real increase in congenital malformations, which are birth defects. So we think this is safe. The technology has gotten better, so the American Society of Reproductive Medicine in October 2012 now basically released a statement saying that this egg freezing is no longer experimental for cancer patients. So this is now standard of care. So the problem with in vitro fertilization and stimulating all these eggs to grow is that with the growth of each of these follicles and eggs, they release estrogen. And so if you have a hormone-sensitive tumor, such as breast cancer, you don't want a high level of estrogen because that can stimulate the cancer to grow. And so we use what's called aromatase inhibitors. This is a medicine that prevents basically conversion of testosterone to estrogen. And the overall levels of peak estrogen that you will reach in your IVF cycle will be much lower. So the average range is anywhere from 58 to 1,166 in this one study, with an average mean estradiol level of 405. So that's pretty typical to what is a normal menstrual cycle peak estrogen level. So it could be anywhere from 250 to 500. So this is pretty much on a physiological level now. And there's studies that have been performed, and there's no real increase in the recurrence of cancer in these patients that have been on letrozole with a hormone-sensitive tumor. And so the only difference is that we will start this medicine, the aromatase inhibitor, usually called letrozole, before or during the stimulation, so that the overall hormone levels are much lower. And then after the retrieval, we restart it again to kind of push the hormone levels down. So in the last few years, what's now reported, because the IVF stimulation takes so long, you basically have to start when you get your period. Now there's more reported of random start IVF. So no matter where you are in your menstrual cycle, instead of starting at the beginning, we'll basically start anytime. So that way, it's about a 2-week process. So you really can start immediately. So depending on where you are in your cycle, you'll get the gonadotropin stimulation. We want those eggs to be stimulated to mature, so we get mature eggs. And then depending on where you are in your cycle, you'll have a GnRH antagonist added on. And so what this medicine does is it prevents the LH surge. And we do a little bit of different protocol here. We actually start the GnRH antagonist first to try to decrease the hormones because we don't know what the high hormone effects of these egg qualities will be, because there's no live births from these protocols yet. They're just basically just freezing of embryos, but we know we can get eggs, we know we can get embryos from these protocols. So the ACG is the same when the eggs are ready, and the retrieval is exactly the same. The benefit is that the time frame is shorter so that the patients don't need to delay their cancer treatments. So the advantage of the random start IVF stimulation is that it's basically immediately IVF start. There's a short delay before chemotherapy or radiation can be started. It's usually completed within 2 weeks. The disadvantage is that you usually will obtain less eggs and therefore less embryos if you're fertilizing them. The quality of these eggs and embryos are unknown because when they're stimulated, it's a high hormone environment. We don't know if this affects the quality of the eggs or embryos, but they have been able to be grown to day 5 and be able to be frozen. And there's no human live births from these methods yet. So in vitro maturation, the first successful in vitro maturation was reported in 1991. And basically in these studies, women at any point of their menstrual cycle will have eggs retrieved without stimulation. So these eggs are at different levels. Some are mature, some are immature. And what they do is they obtain these eggs and they try to mature them in the lab and then put back embryos. Or you could freeze them and put them back later. So at any point when you have cancer, you go in, you take out as many eggs as you can without stimulation and just try to mature them in the lab. And there are embryos reported and live births reported from this technique. So the advantage is that there's no stimulation of the ovaries. There's no cost because the gonadotropins are quite costly, and there's no delay before cancer treatment, so you can do this immediately. The disadvantage is there's a high rate of aneuploidy, so basically what that means is that there's genetic abnormalities, like Down syndrome or other multiple genetic abnormalities. There's suboptimal embryo development, so they don't grow as well. A lot of this is caused by genetic abnormalities. There's lower rates of implantation and lower success rates. And so in animal studies, but not in human studies, there have been a lot of advances. Basically, they've been able to obtain these really early follicles from either fresh or frozen ovarian tissue, and then they were able to use these eggs, mature them in the lab, and actually get births. But this hasn't been able to be performed in humans yet, so maybe something for the future. So the standard of care really at this point is to get mature eggs and basically whatever is immature at the time of retrieval to try to mature them in the lab, but not to freeze the immature ones. So I want to talk about ovarian cryopreservation or freezing ovarian tissue. And so in the upper left is an ovary, and the eggs or the oocytes usually are on the outer layer of the ovary. So one technique, which is experimental at this point, is to remove one entire ovary or a piece of the ovary before the chemotherapy radiation treatment. So one ovary is taken out, one is left in because you may not become sterile from that. So the one is taken out. The one that's taken out is usually dissected. The outer cortex where the eggs occur are basically removed from the rest of the ovary. They're cut up into little strips and basically frozen as small strips. And then after your cancer treatment, those pieces of tissue can be transferred back. And so in this picture, it's actually sutured back into the pelvis, and people can have ovulations. There's been pregnancies reported from this. And in other studies, which I'll show you in the next few slides, sometimes you can put the tissue in your forearm, and so that basically helps with IVF retrieval if you want to stimulate that ovary and get eggs. So this is autotransplantation. So the first successful human autotransplantation of frozen ovarian cortex tissue occurred in 2000. And basically this woman was able to resume her menstrual periods because of the function of the ovary that was implanted. This is one called a heterotopic implantation of the forearm. And so they basically put it in the forearm, and then you can stimulate. You can see a little bump, which is in the red circle there. And that's because there's an ultrasound, you can kind of see there's a dominant follicle. And from there, there's basically an egg that can be retrieved. And after they matured it in the lab, basically it's a mature egg there. There have also been basically reimplantation of that tissue onto the ovary that's left. So you remove the cortex of the tissue that's left, and they sutured pieces of cortex onto the ovary. And following this technique or putting it back into the pelvis, there's actually been pregnancies spontaneously from the patient from spontaneous ovulations. So the reason why this is experimental is there's only about 15 women that have conceived through this method, which is about a third of the patients that underwent the autotransplantation. There is no cases of entire ovary being cryopreserved and placed back, and that's because of the technique of cryopreservation. It usually needs to be really thin so that the fluid can actually penetrate. What we don't want is a very large piece. It's very slowly frozen. It forms a lot of ice crystals in the tissue. So the problems with autotransplantation are cortical ischemia, which basically you're putting the tissue back, but it doesn't really have its own blood supply. So what happens is it undergoes ischemia, which is lack of oxygenation, nutrients, and the tissue and the eggs are lost quite quickly. So there's about a 50 to 90% loss, and the function is only approximately 3 years at the most because of the rapid loss of function. There's difficulty cryopreserving the entire ovary, And one thing that we worry about is that if there's a cancer that can spread or be malignant and can go to the ovary, once you take this tissue and put it back into the patient, that cell can actually be reintroduced. So that's a risk of this technique. So overall, the experience is limited. There's about 15 births, and at this point, it's experimental. So there's a consortium that does this. UCLA just joined that. We don't have an active protocol. We're still working with the hospital to try to coordinate many departments to get involved in cryopreserving ovarian tissue. Just want to talk briefly about the GnRH agonist and antagonist. So this is basically medicine. These are injections that will put you or the patient at medical menopause to try to rest the ovaries. So overall, it's controversial. There's papers coming out and basically saying this helps ovarian function. Some say this actually worsens ovarian function. So at this point, it's controversial. It's not recommended uniformly. It makes more sense if you have a hormone-sensitive tumor, things like that, because it kind of basically doesn't stimulate that tumor to grow. So the GnRH antagonist blocks the GnRH receptors, so it basically works immediately, where the GnRH agonist basically flares you or causes a stimulation of the ovary first before it shuts it down, so that's a longer delay before chemotherapy should be started. And you can basically give both at the same time, because the GnRH agonist is usually very short-term medicine, and GnRH agonist, it can be a 1-month term medicine. So sometimes you'll give it together for a short delay, and then you can give it for long-term for the entire duration of the chemotherapy. So in males, the average age of spermarchy, which is the age that sperm production starts, is 13.4 years. And any damage along the genital tract will affect the sperm quality and if you can get sperm. So damage to the testes directly or anywhere along that tract. So in males, it's a little bit more difficult for prepubertal. Basically, pre-puberty means that they're not producing sperm. So the difficulties of obtaining sperm is very difficult. So the techniques that we have are testicular shielding. Again, you're blocking radiation and damage to those testes. You can do what's called a testicular, it's basically a epididymal aspiration or testicular extraction, which are basically biopsies or inserting a needle into the testes and trying to obtain sperm. So even though they haven't fully reached puberty, sometimes there's some sperm production, and if you can retrieve either mature or even immature stages of sperm, those will still be able to be used to fertilize an egg. And then there's a basically the same equivalent to the female, is that you can cryopreserve the testicular tissue for future use. And so that, again, you have potential to reintroduce a malignancy if there's a basically metastasis to the testes. And so with testicular cryopreservation, there's no human pregnancies reported from this technique. But there are basically pregnancies reported in animal studies. And in these animal studies, you can take testicular tissue, freeze it, basically reintroduce it after cancer treatment, or you can take just the stem cells from the testes and then reintroduce it after treatment. And in animal studies, these have yielded basically sperm that can obtain pregnancies. You can also take testicular tissue or these progenitor, basically germ cells of sperm production and put them in different animals. So put it in a separate animal, have them produce sperm, retrieve the sperm, and basically fertilize. And basically, you can also take early immature sperm and fertilize, and basically, not fertilize, mature that in the lab. And so for animal studies, these work, but in humans, they haven't gotten into work yet. So maybe something for the future. So for postpubertal, it's a lot easier. The same techniques are there, but we usually will recommend freezing sperm, and that's usually through masturbation. And if that cannot be done, there's electroejaculation or vibratory stimulation. Hopefully, they don't have to do that, but basically, you want to collect as much sperm as possible before the chemotherapy and radiation. So I put this picture in because we want patients to know that you don't actually need a lot of sperm or a lot of sperm in a big sample to actually obtain a pregnancy. So you can do what's called intracytoplasmic sperm injection. It's abbreviated ICSI. And in this picture on the left side, it's just a holding pipette with a little bit of suction. The round thing in the middle is an egg or an oocyte. And the thing coming from the right side is a glass micropipette. It's just basically like a very thin glass needle. With that glass needle, they can draw up one sperm and inject it specifically into one egg. So you really only need a very few number of sperm. And this can basically fertilize the egg. So if you have immature sperm that can't swim, can't penetrate, we can actually put it in. And so for patients that have a higher sample, you can do inseminations if they have a lot of sperm, but if not, and it's very limited, you want to do this technique, and then the sperm that are left, you actually can refreeze again, and a lot of times they'll survive the refreeze. So with this technique, the ICSI, the first human pregnancies were reported in 1992, so this technique has been around for some time. There's different stages of sperm production. The spermatogonia is a stem cell stage, and that basically can regenerate itself. And then along the differential pathway is the primary spermatocyte, which has 46 chromosomes, and then it goes to secondary spermatocyte, which has 23 chromosomes, and then the spermatids, and then mature sperm. So as we know, we get half our genetic quality from our parents. We have 46 chromosomes, 23 are from the egg, 23 are from the sperm. So basically with ICSI, from the sperm, the spermatid, and secondary spermatocyte, if we inject it into the egg, pregnancies have been obtained from this technique. And the primary spermatocyte, they can actually try to mature in the lab to a further stage, and they've basically gotten primary spermatocytes basically matured and fertilized with live pregnancies from that. So the male equivalent for GnRH agonist or antagonist is basically to put someone into basically shutting down their testicles and kind of like an andropause. But in males, this doesn't really work. It doesn't really preserve their fertility. There's no studies that show this works. So this is really not effective in male patients. As a summary for males, you should definitely do testicular shielding whenever possible. Sperm cryopreservation is definitely recommended. Testicular sperm extraction is based on the clinical information. This may be a viable option. The GnRH agonist and antagonist are ineffective, and basically cryopreservation of the testicular tissue is experimental at this stage. For females, again, ovarian shielding, definitely do that. oophorplexy is basically taking the ovaries out of the pelvis, and only do that when it's appropriate, such as radiation to the pelvis. Embryo cryopreservation has been around for a long time. This is standard IVF. Definitely consider that. If the patient is a female and doesn't have a partner to fertilize, or at this point doesn't want to use a sperm donor, the oocyte cryopreservation has gotten good enough. It's still not to the level of the embryo cryopreservation, but it's good enough where we can consider doing that at this stage. The GnRH agonist antagonist is considered controversial, so you probably have to talk to your reproductive endocrinologist. In vitro maturation is, again, experimental. There's no human pregnancies reported from this from unstimulated or people that are prepubertal. And then ovarian tissue cryopreservation is also experimental at this point. Just want to talk really briefly about basic cancer survival and what to do afterwards. And so we'll undergo usually fertility testing. So in the female, there's 3 ways to test your basically ovarian function or your ovarian reserve. And the first 2 are blood tests. It's called an anti-Müllerian hormone. This very small follicles in the ovary will produce this hormone. So the more small follicles you have, it indicates that there's more resting, basically inactive eggs in your ovary. So the early stage, basically there's a constant recruitment of eggs, and that these early stage eggs kind of represent the overall resting pool. And so the higher the AMH, which is representative of the hormones that these eggs will produce, the higher number of resting eggs you'll have left. Day 3, FSH and estradiol. On the 3rd day of your menstrual cycle, the FSH is a hormone released by the pituitary gland that stimulates the ovaries to mature eggs. As the eggs mature, it produces estrogen. So in the early stage, if the estrogen is low, that's good. We like it low. And if the FSH is low, that also means that there's better ovarian function. The brain doesn't have to work very hard to stimulate eggs. That means there's a lot of eggs left in the ovary. As the ovaries start failing, the FSH starts rising. And if the FSH gets high, that means there's very low number of eggs or poor ovarian function or reserve left. And the last one is basically an ultrasound. What we do is a baseline antral follicle count. And we do an ultrasound, we look at the ovaries, and we see how many small follicles there are on each ovary. The more follicles there are, again, it shows that there's more remaining ovary, eggs left in the ovary. For the male, we usually do a semen analysis. And basically what the male does is basically masturbates, and we look at parameters of the sperm, usually the volume of the ejaculate, the concentration of the sperm, how well they're swimming, and how normal do they look under the microscope. And for blood tests, the sperm concentration correlates positively with the testicular volume. So if your testicles shrink, that usually means the sperm quality and the hormone production is declined. And the basically higher the inhibin B, the better the sperm production. And with FSH, Usually the higher the FSH, the worse the sperm production. So age factor in women, so basically the pink line there shows maximum fertility. So fertility in women starts decreasing around age 32, and with age it increases more and more dramatically. And the miscarriage rate increases. So the women are born with all their eggs. As they get older, the egg quality will decrease. The genetic abnormalities within those eggs basically increase. So we see the miscarriages will increase. So with people that have cancer, they've had chemotherapy, radiation, we basically will move them along further because their egg numbers and their egg quality may be a little lower. So this is just to let you be aware. So if you're a survivor, you don't want to kind of delay too long. You want to really get in and see what your ovarian function looks like, and if you need help to obtain a pregnancy, do that earlier on. So I just wanted to briefly talk about a few of the fertility treatment options that we use in the clinic often. This is clomiphene citrate, or often called Clomid. And the dose is anywhere, these are 50 milligram pills. It's usually anywhere from 1 to 3 pills, but some studies will use up to 5 pills. And you basically take this for 5 days. Usually the 3rd day of your period, you start the medicine, or the 5th day of the period. And if you can ovulate, then we usually keep the same dose. And if you can't ovulate, we'll increase the dose. So this is best for people that don't ovulate. For people that are younger or have a lot of eggs left, this is not a very strong medicine. People that have very short cycles or problems with ovulation, or if they don't want to do more aggressive therapy. So the pregnancy rate with this medicines in people who don't ovulate at all is about 15%. If you're ovulating, the rate is lower because you're not getting pregnant and there may be some other cause. The negatives, it does have some medicine. The way this medicine works, it tricks the brain to thinking there's no estrogen, so it releases more FSH to stimulate eggs to grow. And so it also tricks the uterus and thinking there's no estrogen, so the lining for implantation is a little bit thinner, so implantation rates can be lower, and the cervical mucus is not as favorable. And so sperm has a harder time penetrating through the sperm to get to the egg. The risk of multiple gestations is anywhere from about 5 to 10%, and most of these multiples are twins, so you usually don't see triplets or anything like that very often with the Clomid. So the next stage of medicines are gonadotropin injections. This is a more aggressive treatment. And basically these are daily injections, typically requiring about 7 to 10 days of injections. And these are injections of FSH and LH, or HCG. The dosage is anywhere from 37.5 all the way up to about 450 international units daily. The pregnancy rate per cycle, depending on how aggressive you are and how many eggs you ovulate, can be anywhere from 5 to 25%. The benefits is that you often will ovulate multiple eggs, so that increases your chance of pregnancies. And this does not antagonize the lining, so your lining with all the hormones being produced by multiple eggs usually is better, and the cervical mucus is usually better. So there are some negatives. It's kind of hard to adjust the medicine. So 1, the medicine costs more money. 2, it's a daily injection. 3, you need a lot of monitoring. So often every 2 days or 3 days, you'll come in for an ultrasound and blood test to kind of see how you respond. Even though you're on certain medicines for some cycles, every cycle can be a little bit different, so we kind of have to kind of monitor and adjust as we go. There's also a chance that you get multiple eggs to ovulate, higher chance of multiple pregnancies. We can hyperstimulate or overstimulate the ovaries. And basically, with the high estrogen, there's more chance of blood clots, things like that, because estrogen causes more coagulability. There's also some risk of cancellation. If you have too many eggs, your doctor may not want you to get pregnant on that cycle because the risk of multiples are too high. And then you can also get what's called a ovarian hyperstimulation syndrome, where the ovaries are stimulated too much. And even if you're pregnant or not pregnant, they keep on producing a lot of fluid, and then your belly fills up with a lot of fluid. The bloodstream is very concentrated. You get more blood clots, things like that. So we don't want to overstimulate. With the Clomid or with the gonadotropin injections, for the sperm side, you can either do timed intercourse. We know when you're going to ovulate, or we make you ovulate and you have timed intercourse at home, or we can do what's called an intrauterine insemination. If there's enough sperm, they'll collect the day of the ovulation. We basically spin the sperm down to collect the sperm and not the ejaculate. The ejaculate, if it goes into the uterus, will cause a lot of cramping and push the sperm out, and the female will be very uncomfortable. So we only want to obtain, or what we call wash the sperm. And so we basically take the sperm, load it into a catheter, go through the cervix, and place it into the uterus. This gives a higher number of sperm closer to the eggs, because most of the time the sperm sits in the vagina, and it doesn't all go into the uterus. So this increases the chances of pregnancy. So again, we talked about in vitro fertilization, and this is also a technique that we can do after treatment of cancer to try to get more eggs And also if you want to do genetic testing, which I didn't really talk about, but you can also do genetic testing for screening of the embryos. And again, we can do ICSI with this. So if there's very few sperm, there's no option of doing intrauterine insemination. We really have to go straight to ICSI and basically save each sperm and use them sparingly. After you form embryos, this is an embryo transfer. On the upper left, it's an embryo transfer catheter. It has an outer, more rigid sheath and a very thin, floppy inner catheter. And under ultrasound guidance, the bladders labeled, the vagina is on the right and the uterus is on the left. And we usually measure about 1 to 1.5 centimeters from the fundus. And we basically introduce the catheter into the uterus. And under ultrasound guidance, we put it in the most optimal places, which is usually about 1.5 centimeters from the fundus. Again, we usually use Valium, so the patient's happy. So with in vitro fertilization, as we know, the chances of pregnancy will decrease with age. And that's basically caused by two things. One, as the woman gets older, the quantity of the eggs are less. So you have less eggs to work with, and the quality or the genetic abnormalities will increase. So the quality will decrease. And that kind of lets us know that with age, the pregnancy rates decrease. And that's from the quantity and quality. And the female age is the greatest predictor of success in IVF. And so on the left side, the top line is the pregnancy rate. The second line is the live birth rate. So the difference between the two are miscarriages. And then the third line is the singleton birth rate. So the difference between the second and third line are multiples, usually twins. And then the graph on the right is the miscarriage rate. So as you get older, the miscarriages increase. So if you see on the graph, like if you're at 43, 44, you get pregnancies that are low, but then half of those are live births. So the other half are actually miscarriages. So donor eggs, if you have a uterus that's not damaged, if you didn't have radiation, and you're older or have no ovaries function left with eggs, you can get an egg donor. We can still use your uterus. We still undergo in vitro fertilization to obtain the eggs. You can use the sperm of your partner, and basically we'll put the donor eggs instead of your eggs back, with the embryo transfer. So this graph kind of shows that with donor eggs, despite the age, the uterus doesn't age very much. And then the green basically shows the woman's own age. Using their own eggs with increasing age. So as long as the uterus is good, you can still conceive and carry a pregnancy. What I really didn't talk about is gestational surrogate. If there's damage to the uterus from radiation, or there's problems with the uterus itself, you can have somebody, or gestational surrogate, carry a pregnancy for you and use your own eggs. And the last option is always adoption. Okay, thank you.